please type these questions into the Q&A box, whilst also stating your name and your role or position. I will now hand over to Dr. Lisa Escott, who will be sharing the presentation from her screen.
So just before we start, I'd like to greet everybody and give my personal thanks to NHSBT. I, as the Deputy Chair of the National Blood Transfusion Committee, have been astonished with the rapidity and the ability for us to be able to develop this potential research tool and for it to be integrated into more than one important scientific study. I hope that NHSBT will be able to continue this education programme during the course of these trials, but for this moment in time, as convalescent plasma has been all over the national and international news, I'm welcoming this update from Dr. Escott. So thank you very much, Lisa.
Thank you very much, John. Hopefully everybody had seen the previous NBTC initial presentations from Gail Mifflin, and those are available on the website. I just kind of like to highlight how much has happened over the last few weeks, and now all 23 donor centres are collecting convalescent plasma via plasmapheresis, and we're also setting up additional new donation centres just for plasmapheresis collection. So it's a huge effort on a large proportion of NHS blood and transplant to provide the new convalescent plasma product. I just briefly want to let you know about something that I discovered relatively recently, which is actually convalescent plasma is an older product than I first thought, and the person who won the first Nobel Prize for Physiology and Medicine actually won it for convalescent plasma, and it was in treating patients who were sick with diphtheria. So it's had a long history. The only problem with a lot of these studies and trials that have been done for previous infections is that they're low quality studies, and so there isn't great evidence on whether they work and the safety of the treatments, which is why we're doing trials in convalescent plasma now. How do we think it works? Well, we're giving convalescent plasma so that the antibodies can neutralize the virus and stop invasion of cells in the body. So we're giving a large dose of antibodies, and we're giving antibodies that neutralize the virus and stop the virus entering the cells. And we've been doing specific tests to assess the ability of the virus to enter cells in the laboratory, and that's called a microneutralization assay. Might also help by improving antibody-mediated cytotoxicity and also enhancing phagocytosis in the patient. One paper that's just come out is actually the work that NHS Blood and Transplant has done on assessing different assays for neutralization assay and comparing it against ELISAs. Now, we're doing this because we want to find a product that has high levels of neutralizing antibody test. But the neutralizing antibody test we use is using a live virus, so it's not something that we can do at huge scale. So we were looking for something that was helpful, that could be an antibody test and ELISA that we could do at many more laboratories and do at scale. So if we show here, this is a neutralization titer, and we were using a threshold of 1 in 100 for saying those were high levels of antibodies. And that's around 30 to 40% of the donors that we've tested have got these high levels. When we look at the other antibody tests we used, the ELISAs, we assessed 5 other tests, but the one that showed the most correlation with the neutralizing antibody titer and was able to identify high levels of neutralizing antibody was the Euroimmune ELISA. And we're using that to be able to detect on a large scale the plasma components that have got high levels of antibody. We're using this convalescent plasma in 2 trials. The first trial is the REMAP-CAP trial, and that is for patients and adults who've been admitted to ITU within the last 48 hours and have a confirmed diagnosis of COVID. And they're being randomized to convalescent plasma versus standard of care as one of the REMAP-CAP domains. REMAP-CAP is a platform trial, and so there's lots of different domains. So patients could be randomized to other treatments within a different domain, such as anticoagulation or antivirals or steroids. What we're doing is giving 1 adult unit of convalescent plasma on day 1, and then a second unit on day 2. We're giving at least 12 hours between the 2 transfusions. 1, so we can assess to make sure that the patient isn't developing any serious adverse reactions to the convalescent plasma, and also to make sure the patient isn't becoming significantly overloaded due to the convalescent plasma. We're aiming to recruit up to around 2,000 participants, so up to about 1,000 participants receiving convalescent plasma. But this is an adaptive design trial, so if the effect of convalescent plasma is seen earlier, the trial has been designed so that it will stop, and then everybody, if it's shown to be effective, everybody who would be eligible would be given convalescent plasma. We're also doing a subgroup of patients where we're doing intensive sampling, and this is to assess the effect of convalescent plasma on a patient's viral titer when we're checking it on a regular basis, their antibody levels, their cytokine levels, and looking in great detail the effect of convalescent plasma. At the moment, we've got 36 sites open to REMAP-CAP. We had 3 more ITUs joining this morning, and we've got many more sites that are planning to join in the near future. The recovery trial is a trial for just hospitalized patients, and it differs to the REMAP-CAP trial in a couple of important ways, in that there's no time frame for entry. So patients could be entered if they have COVID infection and it's active disease, so there's still PCR positive, but later in the course of their admission. It also includes children and neonates, so that we can offer convalescent plasma to any age, so there's no exclusion to that, and also pregnant women are eligible for inclusion to this trial. Our first child was randomized to recovery earlier this week, and that's been in the press recently. We're giving the same convalescent plasma that we're giving in REMAP-CAP and the same dose in adults. So we're giving 1 unit of convalescent plasma on day 1 and the second unit on day 2. For children, we are giving a weight-related dose up to a standard adult unit. And we have identified neonatal units for children up to the age of 1 that have all the appropriate tests for neonatal use. If you have a child who needs transfusion, you just give an adult unit and then waste the rest of the unit. This is a much bigger trial, and we're planning to recruit at least 5,000 participants, with about 2,500 people receiving convalescent plasma. This has opened more recently, so it opened at the end of May, and we've already got 9 sites open to the trial and more sites coming on a regular basis. I thought it'd be interesting for you to see actually where the sites were opening. So what we've done is put up which sites have got REMAP-CAP sites open, which sites have got recovery sites open, and which sites are in setup. So although there's not as many sites that are actually open to each trial, you can see that most RTCs have got at least 12 hospitals being set up either to REMAP-CAP or to recovery or to both. So there's a huge amount of activity at the moment across all RTCs, which is great to know about. And thank you for all the support you've given to allow these trials to be set up and to randomise participants. Just want to give you a bit of evidence about the evidence up to now about convalescent plasma and COVID-19. And there was a Cochrane systematic review published earlier in May, which showed that there are 8 case series published with only 32 participants. And really, from that data, we couldn't really assess whether there was any effectiveness or safety of the convalescent plasma. There were kind of encouraging signs, but there was no good evidence that it was effective and safe. So we need these randomized controlled trials to be able to say whether it works, because we don't know yet, and to assess whether it's safe. We do have some initial safety data from a large extended access program in the USA, which has given over 5,000 patients convalescent plasma. And only a small number of people, less than 1%, had a serious adverse event within 4 hours of transfusion. And those were mainly transfusion-related acute lung injury or transfusion-associated circulatory overload. I think of interest, they only monitor the patients for up to 4 hours after the transfusion. So we don't really know the full extent of adverse events that happened over the first 24 hours. And so it also means that although this suggests that it looks safe, we don't know whether there were more cases that occurred after that 4-hour window. And hopefully we'll get further data in the future. Because we're concerned about ensuring safety of convalescent plasma, we're working really closely with SHOT. And SHOT has very kindly recreated their TACO checklist for convalescent plasma, highlighting what to check for. And we're asking that all trials patients are assessed for TACO prior to administration of the convalescent plasma to reduce the risk of this complication occurring. We're also setting up a data sharing agreement with SHOT to ensure that we're closely liaising and communicating between the trials and the SHOT team to ensure that we have information about all serious adverse events that are happening within all the trials. If we look worldwide, at the moment on the clinical trials databases, there are 48 convalescent plasma randomized controlled trials around the world. Multiple ones in America, South America, China, rest of Europe. But there's only 8 randomized controlled trials around the world that are planning to recruit over 500 participants. And the 2 largest trials in the world are the REMAP-CAP trial and the recovery trial. We're obviously, to get evidence from such large trials, we actually need donors to help provide the convalescent plasma. And a recent analysis by Rachel Johnson and her team from NHSBT has looked at what are the types of donors who are more likely to produce these very high level antibodies. And what we've found is it's people who've got the highest level of antibodies are more likely to be men. They're more likely to be slightly older, so 35 years or older. And they're people who are likely to have required hospital admission. So up to date, Dr. Giardini, a consultant at GOS, is the highest antibody level donor. And it was just, we would like to encourage anybody who's got a positive antibody test that may have been done locally and they know that they're able to donate, if they could register their interest in donating. And you can do that either by calling phone number 0300 123 2323 or via the website. and just let them know if on the phone number that you're an NHS worker. The other thing is, if your hospital is not involved in either of the trials and you would like to be, or like to know where you are in the setup of the trial, then we've got a CTU email that you can contact, and we can help set things up for you. And we're working with lots of different hospitals at the moment and welcome any more interest. Also like to say thank you for everyone who's donated up to now. We really appreciate what you've done, especially after it's so soon after recovering from the COVID infection. So thank you again.